you all for coming, and thank you as we open up and celebrate Vermont's newest opiate treatment hub. More importantly, I want to thank everyone who made this event and the opening of this hub possible. Before I get into the long list of thank yous, I want to talk about why the opening of this hub is so important to all of us. First, it provides critically needed services in this region. Also, as the sixth hub in our statewide hub and spoke treatment system, it helps expand our capacity for treatment services. In fact, the opening of the temporary location at Northwestern Medical Center this summer contributed to the elimination of Chittenden County's wait list for treatment, which we announced in September. Further, it adds to the statewide capacity, allowing us to quickly provide treatment services to those in need all across the state. Ensuring timely access to treatment is important because it saves lives. People in treatment are much less likely to die of overdose. It also helps prevent prescription medicine misuse from crossing over to heroin use. As well, people start recovery sooner. It makes it easier for those in need to ask for help. And it shows we care deeply about our sons and daughters, our parents and sisters and brothers, and our friends and neighbors who struggle with the chronic disease of addiction. To put this in human terms, I'd like to share something Burlington Police Chief Brandon Del Pozo said at that September press conference. When talking about why timely access to treatment was so important, he shared that in the past, on more than one occasion, when he's had to tell parents that their son or daughter wasn't able to get the treatment they needed for weeks or months, they've asked if they can chain their child to the bed, because that's the only way they can ensure they still will be alive when that day comes. As the father of two daughters, I can't imagine living day to day with a type of fear for your child's life. So when we say we're here to celebrate this opening, it's because it is a celebration. Having greater access to treatment is that important. In 2014, Governor Peter Shumlin did a great service for Vermont when he put a spotlight on the impact and prevalence of opioid addiction across our state. But even before that, many in the treatment community had already begun the critical work of building our hub and spoke model, which has played an incredibly important role in our effort to combat this damaging epidemic. And it's recognized as a model to other states as well. As I said at that September press conference, this is not a spike the football in the end zone type of moment. Access issues continue. There aren't many more people out there who need treatment but don't seek it. There are many more people out there who need treatment but don't seek it. And this will be an ongoing effort to keep waiting lists short and move towards our goal of treatment on demand. But we are one of the first states to approach this goal. And this is thanks to the efforts of many in this room and much beyond. So I want to thank you for that work. To start, I want to thank Jason Goguen, Dr. John Brooklyn, and the entire BART staff for your work to open the center and the critical services your team provides to Vermonters. I also want to thank Jill Barry Bowen and the Northwestern Medical Center. Your willingness to open a temporary hub in June meant we could provide treatment to this community much sooner, which means lives were saved. And to our team at the Agency of Human Services, Secretary Gobet and Field Services Director Kristen Pryor, as well as the Department of Health, Commissioner Levine and his team, the Division of Alcohol and Drug Abuse Programs, Blueprint for Health Director Beth Hansman, Jolinda LeClaire, and the Opioid Coordination Council, and so many others. Additionally, I want to thank our entire congressional delegation, Senators Leahy and Sanders and Congressman Welch. Their support has been critical to developing Vermont's hub and spoke system of care. And thanks to our state legislators for their ongoing contribution and collaboration in addressing this epidemic. A couple are here today, including Representatives Barbara Murphy and Carl Rosenquist. I could go on, but the bottom line is we're all in this together, and together we can continue to lead in addressing this public health crisis. I'd now like to invite Health Commissioner, Dr. Mark Levine, to say a few words.
Thank you. Vermont has long recognized opioid addiction as a chronic disease that requires treatment, like any other chronic disease condition. This may sound like a novel concept to some, but it is a major guiding principle in Vermont that has revolutionized care of substance use disorder here. And it has been a large part of our success and why we are viewed as a national model. We've taken a comprehensive approach to help those who suffer from addiction to get into treatment, stay in recovery, and to prevent people from starting down the destructive path of opioid misuse in the first place. Hubs are so critical to this approach. They are regional treatment centers that treat patients with complex needs. They are sites for centralized intake and initial management and stabilization of people whose lives have been anything but stable. And they are where initial decisions are made, tailoring the treatment plan to the individual's own particular situation and needs. And they embody the key concepts of our model: availability of medically assisted treatment, availability of counseling and social services, integration of care, coordination of care, and education and outreach. This newest hub represents one of the more important achievements in our efforts, helping to close capacity gaps in our statewide system. We've worked hard over the years to make treatment accessible across the state for all Vermonters, near to where they work and live. This is, of course, especially important in a rural state. Ensuring timely access to treatment is important because it saves lives. Knowing there is rapid referral and availability of treatment provides hope and capitalizes on capturing people when they become motivated, a process that can take a long time for some. We know that people in treatment are much less likely to die of overdose. To that end, and knowing that as many as 8 out of 10 individuals may actually not be actively seeking treatment, we must intensify our efforts to connect with them wherever they may be and as often as possible. Through programs such as needle exchange and harm reduction strategies like Safe Recovery, through novel initiatives to locate people and rapidly connect them to treatment resources, like a national program we've been asked to participate in pilot by the Substance Abuse and Mental Health Services Administration, or to offer initial access to medication-assisted treatment in new clinical settings, such as emergency departments, with peer recovery counselors. Through our hub-and-spoke system of care, we are better able to help people get the assistance, treatment, and supports they need. Pregnant women and others who are using intravenous drugs are prioritized for access to treatment. People can start recovery sooner. I always like to emphasize that the first day of treatment is really the first day of recovery. And early intervention can help prevent prescription medicine misuse from crossing over to heroin use. We recognize the progress we've made and the lives that have been saved as a result. But substance use disorder and drug misuse are complex and extremely difficult challenges with a too often tragic impact on individuals, their families, and communities. So we look forward to continuing to work closely with our state and federal partners and with Vermont's medical and substance use disorder treatment community to prevent new addiction, to help those who need treatment, and to stop people from dying of drug overdoses. And in that spirit, I'm happy to introduce Jason Gogan, who is the Regional Program Director of Operations for BART.
So I do presentations all around the country. And the last time I actually wrote one out, I had to do it in Orange County. And let me tell you, it bombed. It was not good. But I tried again. So I'm going to do this. But now, before I get started, I want to thank a couple of people that I see in the room today. First of all, I hope you all got a chance to see this beautiful facility. Mike Connor Contract, the building came out great. Thank you. Did a great job. Secondly, I want to start off by thanking Governor Scott and leading this charge against this disease. Without you and former Governor Shumlin, none of this would be possible. I want to thank Tony Fallon, Brandon Olson, and Aaron O'Keefe from ADAP, and Cynthia Thomas. Your team's wonderful to work with. We're lucky to have them. I'd also like to thank two of my directors, Tina Plassick, who's in charge of St. Johnsbury and Newport, and Lance Woods, who oversees Berlin and is our interim director right here in St. Albans. You both understand what it means to help out patients and to do whatever it takes for them to receive MAT treatment. For this, I thank you. Lance, I couldn't have done this without you. I appreciate you putting in many, many extra hours over the last couple of weeks. When I was at a young age, I was taught by a very important man in my life that if you're going to do a job, you do it right. He said, I don't have a problem if you're aiming high and miss, but I'm going to have a real issue if you aim low and hit. I cannot thank you enough for your support and courage during this time. You have shown me to fear nothing, and I am grateful for the drive that you have given me. Thank you. I want to share a personal story with you. A little over 5 years ago, I was diagnosed with the worst cancer imaginable. I was told within 3 weeks I needed to go to Massachusetts or Texas to have a surgery called the mother of all surgeries. So on the same day my twin boys turned 2, I went to have this procedure done. I told the surgeon, Dr. Lambert out of Massachusetts, I said, just make sure I wake up. I don't care how much pain I'm in, just make sure I wake up. 12 hours later and 58 staples, I woke up and I knew, with the support of my family, the most beautiful woman I ever met, my wife, I could beat this word called cancer. And let me tell you, I beat it. I also realized that I needed to do something I could be proud of. I wanted to help people overcome the biggest challenges of their lives. With many opportunities to choose from, I chose the field of opioid addiction. This is how Bart and I found each other about 3.5 years ago. I always say to our patients, you don't have to be fearless, just don't let fear stop you. When you hit rock bottom, don't be scared. This is an opportunity to rebuild your life. Do what you think is right. Become the person that you know you can be. Be a provider for your family and become something that you, most of all, are proud of. I ask you not to judge our patients. If you don't know our patients, I'm sorry to say, but you will. And what I mean by that is, substance abuse disorder can affect anyone at any time. It has no boundaries. It has no limitations. It can affect our brothers, our sisters, the mailman, the school teacher, our nurse, lawyers. The list goes on. There's no end. We live in this great state because we love small communities. We all know each other, so let's support each other. Never turn your back on someone in need. Let's be a leader for our nation and share our successes and failures during this battle. Listen, no one ever chooses addiction, but it is something that we deal with daily. Whether you're addicted to smoking, drinking coffee, gotta have that cup of coffee every morning, Diet Coke, biting your nails. Sooner or later, we all make a choice. Enough is enough. So we ask for help to stop these addictive behaviors. If it is due to an addiction of opiates, this is why Bart is here. We have been providing this type of treatment for years, since 1977, and we are recognized around the world as being a leader of fighting opioid use disorder. We will work with our community partners to wrap our patients up with all the services they might need. We will never lose hope, and we will never stop believing in our patients. We are all the same. Some of us go down different paths. Please don't block a path. Let our patients choose the path that works for them. We only have one life to live. Tell the patients, don't be afraid to fail. When you fail, pick yourself up, fail again. Fail the way you would want to fail. Pick yourself back up again. I want to thank you all for coming today. Before I introduce Jill Berry-Bowen, which I just did as I said that, I want to thank Jill. Jill's the CEO of Northwest Medical Hospital. We got this facility. We had to go through some permitting issues. Things take time. Things take time. I remember when I first hired Mike, I said, I need this place open in 8 weeks. Jason, that's unrealistic. So we went up to the hospital, and we opened up there temporarily. We've been open now over a couple of months. We're already at 235 patients. And the phone keeps ringing. We don't expect this to slow down. I hope it does. We all hope it does. But we're here to provide. But we need everybody's help. So I've said enough. Jill?
Thank you very much. Well, it's certainly an honor to be here and to follow that beautiful story. Jason, thanks for sharing a part of you And that's what we do in this community is we share parts of ourselves to make a better place really for the greater good of our community. So our community, like many areas of Vermont and the nation, really does have a true need for a hub-level services to help those facing the most challenging of addiction circumstances. As we've known for years, Franklin County residents have been very challenged to receive this level of service in this community. Therefore, they've been traveling long distances, preventing them from maintaining their sustainable employment and focusing on the treatment goals that are necessary for their healthy recovery. The hub services now complement our community's existing spoke services. The addiction treatment that's provided by primary care providers, Northwestern Comprehensive Pain and Addiction, the Howard Center, and other community partners that have been providing addiction treatment in our community for years and experience great collaboration for our patients. NMC, as you've heard, is very committed to the hub level of addiction treatment that is needed, and we're grateful that it's now available. We're pleased to support BART in opening this clinic, and our NMC campus was available in June, and we're so glad that we're able to make that happen. This is just an example of our sincere commitment to partnership and collaboration for what this community stands for. So BART has a very important role in our community, providing the methadone treatment and other daily dosing options, which supports really a higher level of care that is necessary. This is about transitions of care. This is about warm handoff. We talked about this is people, this is our community, our neighbors, our friends, and integration to make sure that we're connecting the dots for a true continuum of care for our community. So BART is a very valuable part of this continuum to help our members of this community to overcome addiction, and it can only be done with this partnership. Meanwhile, as we treat addiction, and we must do that together, we're also aligned in partnership for Rise Vermont. How do we embrace healthy lifestyles in order to prevent addiction from happening in the first place? And we're also going to work together on that to accomplish as well. So thank you very much for the opportunity to partner. I would love now to introduce John Tracy, who is from Senator Leahy's office.
Thanks a lot. On behalf of Senator Leahy, it's a pleasure to be here today because this is about coming together for this project. There's over a course of years, Senator Leahy has had committee hearings in Vermont to try to get a handle on the opioid crisis that we've been dealing with. And part of that is able to bring back to Washington ideas that would work for other parts of the country. And Vermont's a leader now. We're making success. If you want to read about the hub and spoke model, there's an interesting article in Vox with a V, and it talks about the hub and spoke model and what Vermont is doing. And the beauty of that, because rural states have other challenges, you can enter at the spoke if you need to, or you can enter at the hub, depending on the intensity of the care that you need. And the flexibility really works for people. And that Vermont, through Governor Shuman and followed up by Governor Scott, recognized that the opioid issue is a public health issue. And it's a chronic disease. And as the commissioner addressed, we need to get other parts. We need to get to the education and prevention. But the treatment part, as any healthcare practitioner will tell you, managing a chronic disease, whether it's diabetes or hypertension or substance abuse, is difficult. Maintaining the medication and doing the other things you need to do. So it's a chronic illness, and Vermont has the right approach. 64,000 people died in 2016 on substance abuse-related deaths. Over a decade, that's the population of Vermont. I read that in that Vox article. I'm stealing freely from that. But, it's something we really have to get a handle on, and we can't forget the education prevention piece. But the hub and spoke model is really making a difference. Cut down on wait times. UVM Medical Center has stepped up to help train more healthcare practitioners so they can help treat patients. The relationship that you have MAT teams in place with nurses, counselors, and primary care givers, we're very fortunate. And a lot of it's the approach that Vermont has taken. So this is a day to celebrate because it impacts all of us. Every community in the state of Vermont, you see the impact. This is a step that's going to make a difference. And I'd just like to quote, it was German Lopez who wrote the article, and he's talking about Vermont. He says, Vermont has moved to treat addiction as a disease, not a moral failure. And we're on the right track. And it's my honor to introduce my counterpart, Catherine Becker Van Hayes from Senator Sanders' office.
Thank you, John. And as per usual, John stole about half my talking points. But I really, on behalf of Senator Sanders, want to thank the folks at BART, want to thank the governor's office, Jolinda, Dr. Levine, and the health department, and everyone who has made today possible. I also saw some folks here from Notch, the regional community health centers. Thank you for being here for part of that spoke process, because these hubs really work when we have the spokes behind them, so they can do that cross-referral. And I really appreciate the comments that Jason made about the folks who walk in these doors, because these are our neighbors, they're our friends, they're our fellow parents at school, at daycare, they're the people we see at the grocery store. They may be checking us out in line. And so I think it's really important that we do what we can from being here today, when we walk out these doors, to take this message home and into our communities and make sure that people start not just to feel like they can seek treatment, but also that you've got their backs. Because if we want this to work, if we want recovery to stick, reducing the stigma, I think, is a really important part of that process. So just by being here, I think you're part of that message. And as you take this message home with you, really, I would encourage you to think about that. From Senator Sanders' perspective, he is incredibly proud of the work that's happening in Vermont. We are so thrilled to be, as we often are in Vermont, on the leading edge of change. Again, I think that from Bernie's perspective, we know how important it is that we keep these resources here in Vermont. A lot of the dollars that make this possible come through the federal government, and so he's doing everything he can in Washington to make sure that that keeps happening. I mentioned our local community health center earlier. We know that, some of you may know that at the end of September, funding for community health centers, 70% of the funding expired. Bernie is working hard in Washington to make sure that that funding gets reauthorized so that we don't have to close some of the spokes, because that will obviously have a severe impact on the treatment options. So that is one of his major processes in Washington right now, to do just that. And the other thing he thinks a lot about, he's the ranking member on the HELP Subcommittee on Primary Health and Aging, which is a really long way of saying that he is the guy in Washington on our side of the aisle who thinks a lot about primary health and prevention. And so from his perspective, as much as we love seeing these doors open, I hope you're not insulted when I say we'd like to see them close someday, because we don't need them anymore. And so if we could reduce the supply of patients who need to come here, I think that would be a really great thing. And, treatment and recovery is something that we're really figuring out. Prevention's still hard. Prevention's still messy. And there's not a nice bright line that directs you from what caused an addiction in the first place. There's so many aspects of a person's genetics, living situation, lived experiences, trauma, family history that all play into that. And so everything that we can do to help mitigate those factors and really work on economic opportunity is going to be a huge impact for reducing the line and the need of people to walk in these doors. So thank you to all that everyone here today has done to make this possible. Our work isn't over yet, and we're going to keep fighting in Washington and here in Vermont to really tackle this issue head on. So thank you, and with that, I want to turn it over to our third great member of the Vermont delegation, Kevin Veller, representing Congressman Welch.
Good afternoon. As you can see, you have your entire congressional delegation behind you. I am thankful that we don't have yet another member of the United States House, because they would steal everything. There'd be nothing left for me to say. But I will say that Congressman Welch is just so proud of the work that has been going on in Vermont. He would say that this is the Vermont way. We have two governors. We've had two governors of two different parties who have faced this epidemic head on. Vermont names a problem, solves a problem, brings the right people together. He wants to commend you, Governor Scott, for creating the Opiate Council under Jolinda's leadership. And it's a very comprehensive, multi-layer approach to addressing all the issues associated with this disease in a holistic way. For his part, he will continue to work in Washington. This week, it's fighting for not robbing Peter to pay Paul. It's not robbing from the health department the prevention dollars that we need in order to pay for CHIP, health insurance for children. He will continue to fight for fixes to the Affordable Care Act, which bolsters the individual market, because so much of what that's about is getting upstream in population health and delivering the right care at the right time and keeping people well and not just treating for when they're sick. He will fight for full funding for CARA, which is the Comprehensive Addictive and Recovery Act. Congress passed that act. Congress authorized $181 million. That money needs to be shaken loose. Peter worked in the CARA legislation to encourage the NIH to research better alternatives to treat pain beyond opioids, and to encourage better prescribing and alternative ways to treat and manage pain. And thanks to the Opioids Council, he understands that we have seniors on Medicare who also need to benefit from this facility, because as it currently stands, they can only receive treatment in a hospital setting and only for pain. So there's a lot of work that needs to be done, but your collective work inspires him, and he is so happy to be working alongside of you on efforts like this. So thank you. Oh, and I would like to ask you.
Thank you very much. Appreciate it. We'd be happy to take any questions at this point.
Governor, one of the things that Josh said that I thought was really interesting was his appeal to not close any paths to treatment and recovery. And for a lot of people, their path takes them through prison. And we saw some reporting in 7 days that highlighted the fact that it's been 3 years since the state piloted extending access to medication-assisted treatment in prisons. There's going to be a push in the legislature to further expand that, to not kick anyone off when they go into prison. What's your position on that, and will you support those efforts in the legislature this year?
Yeah, obviously, this is an issue that's facing all of us, whether you're incarcerated or walking off the street. We should be proud of the fact that Vermont has a 30-day program now. Many states don't have anything. So we've done good work in that regard. As you mentioned, there is a pilot program that has extended that in at least 2 locations to 90 days. We think it should be longer than that even. Our Jolinda is looking at that with the Opioid Council, and we are looking further into whether we should be expanding that. So the bottom line is we see a need, and we just have to find the resources in order to do it.
When I did the reporting on this probably in 2016, we got an estimate that it would cost around $200,000 to make sure that I believe at least the 90-day or possibly longer than that was available statewide. That's not a lot of money. Do you think that's something you can do?
Well, obviously, we want to do something. We want to expand the treatment for those who are incarcerated. I think we feel it's an obligation, and it puts them on the right path forward. So we're looking into it. I don't know what the figures are. We don't know what the costs are. But we're suffice it to say we're engaged and we're looking into that.
Governor, how will the state measure the success of something like this?
Yeah, it's interesting because as we know the need grows as the epidemic grows, as was mentioned earlier by at least one speaker. When the doors close, I guess we'll know we've been very successful. But that's not going to happen anytime soon. We saw the opportunity in September to celebrate, in some respects, the waiting list that was depleted, and that was a milestone that was worth celebrating. But that doesn't mean it's over. And as I said before, this isn't a spike the football in the end zone type of moment. It means that we should take the moment to at least to celebrate that success, but to move forward and to anyone who needs treatment be able to obtain that on demand. That's our goal. So I look at this, again, as I mentioned before, as a 4-legged stool. It's about the first leg, about prevention. We need to make sure we have education and prevention. We also have to have treatment, the second leg of the stool, as well, then recovery, and we have to have enforcement. So we've been focusing on all of those in some respects. Education and prevention is probably going to be the most successful as soon as we are able to obtain what it is that's going to prevent this from happening and educating those to prevent it from ever starting. But the recovery, treatment, and enforcement. We've stepped up enforcement as well. So it's across the board, and we have a long ways to go. But I think, again, when you compare us to other states, we're ahead of the curve. But that doesn't mean we're nearing the finish line.
Jill and Josh, Jason, sorry, I apologize. What will your guys' organization's relationship be going forward? I assume you'll probably close down the actual clinic at the hospital, but well, maybe you won't. I don't know. But what's the relationship going to be like going forward?
Well, the clinic is already closed at the hospital.
Okay.
The day it closed, we opened here the next day. That's how we
And what day was
transitioned.
that?
I knew you were going to ask me that.
The end of September.
It was the end of September.
September 25th comes to my mind.
Yeah, 26th, 27th. I could get that for you, Catherine. Maybe a little help there. The what? The 28th. We'll go with the 28th.
And just to be clear, it wasn't a hospital clinic. The location was on the hospital, but it was supporting the clinic of BART. It was still the BART clinic on the campus location. So it's just really kind of a transfer. And
It was.
we were housing that for the moment, but it's really the same, all in one.
She made it happen. I mean, it very seamlessly. I reached out to her, and we were able to get in there in 6 weeks, which is kind of unheard of.
So
Jason.
all your people.
Yes,
Yeah.
they're all our bar people. Yeah.
If you could go through the numbers, I think that we were speaking before about the numbers, the number of people accessing treatment, and what we've seen since this facility opened. I think that would be helpful.
Sure.
And where they were going before that.
Yeah, so we've been open a couple of months now, where our census is 235 patients, just at this hub alone. We have a clinic in Newport, St. Johnsbury, Berlin as well. Berlin is around 550. Newport's around 440. St. Jade's 370. We're still bringing in anywhere from 10 to 14 patients a week. We feel that's a responsible, safe amount that we can keep up on the counseling end as well, with our nursing and everything across the board. So we built this clinic to support 700 patients. We hope it never gets to that. But a lot of people have been asking me, when do you think it's going to slow down? I think it's going to slow down around 400 to 500 patients, and then I think we'll see it slow down. Hardest thing right now, as anybody knows, is a patient pick up that phone and call, but then to actually show up and walk through that door and say, I need help. That's the hardest day of any of our patients. I could ramble on and on, so I'm going to stop there with the numbers.
Jason, can you speak to how BART measures success?
Sure. So we individualize it. We run on a harm reduction model, which means it's going to be different for everybody. Okay. So if I get a gentleman that shows up in here who's been using, let's say, heroin for 10 years, 8 bags a day, 10 years. If in 6 months from now he's only testing positive, or a year from now, for the medications that we give him, that's success right there. How long should he stay in treatment? It's different for everybody, and there shouldn't be a time limit on it, because it's no different than working with someone that's battling alcoholism. They're going to relapse probably 5, 6, 7 times in their life. We hope they don't. We hope they quit it on the first time. Same with this as well, but it's going to happen. So we need to stand with them, because if they can't make it with us, they're at the hub because they need a higher level of care. They've burned those bridges with a lot of their primary care docs. Most of the primary care docs that we work with, they'll refer someone to us, and I'll take him back once he's stable. So it's individualized. I will tell you this, that there's media coverage on this every day. We don't hear a lot of good. But you can ask my staff at any site. You could ask me. We see it every day. We see people come in who are sleeping under the bridge, doing whatever they can for their next fix, and in a year from now, with help of our community partners, they're stable, they're providing for their family, they're working, and most of all, they feel like a human being. They feel like they have a lot of self-worth. It's kind of some of the ways we measure it.
Ask a question. What's your position or what's your advice on the potential legalization of marijuana?
I didn't think that question was going to come today. I think the governor and the committee is doing the right thing. They're not too quick to jump. I think when this first was discussed 10 years ago, everybody thought Vermont would be one of the first ones to do it. I think it's good that we haven't. I think that we're researching it and taking our time. I have many different views on that, many different views. I'm going to leave it at that, though, right now.
You mentioned watching people relapse. Does BART track relapse rates?
Do we track the rates? We do on an individual basis. Absolutely, yeah. We have to. We do treatment plans with our patients every 3 months. We update them. We give them goals. We want them to achieve those goals. And then we try to teach them the skills so when they leave our facility and the cravings come back, they know what to do so they don't go down that wrong path.
Have you ever looked at that in the aggregate?
No.
Are you aware of any, or Dr. Levine, any national research on that?
No, and I would really discourage people from using that as a metric to measure the success or failure of a treatment program. Has anybody been on a diet in this room? If you've been on a diet because you may perceive you suffer from overweight or obesity, you all know what the relapse rate is from that. It's a roller coaster course throughout your life. The term yo-yo has been used, and it's chronic disease, obesity. So I would look at it the same way.
One last question for me anyways. One of the things we've heard, I don't know if this is a problem in the hubs, I haven't heard it as a problem in the hubs, but for spoke providers, especially community health centers or practices like that, they really rely on that blueprint Medicaid money to hire counselors, and they feel like once they get someone really stabilized, that person gets a job, they get off Medicaid, they're doing better, and it essentially creates something similar to the reach-up benefits cliff, where they're basically being punished for their success. They're losing out on those blueprint dollars. Are you guys going to do anything to address that?
I'm going to bring either Secretary Gobet or Commissioner Levine, one of the two. Sure. Maybe you can answer that.
Morgan, that's a great question. So basically the question is Medicaid pays for a lot of this stuff, and it was commented on earlier, I believe, by the congressional delegation that Medicare is not a payer in this space, and also some commercial payers are not. And so as we treat this like a chronic disease, we're going to work to get Medicare to participate, and we want to work to also get other payers to participate. This should not be a Medicaid-only program.
I have a question on the national scene. Recently, President Trump declared it the opioid epidemic a national emergency. So my question is, what additional resources on the federal level does that open up?
Well, at this point, we're not aware of any at this point. Has it helped? Sure. Anytime we can highlight and put a spotlight on the issue, I think it's helpful. I believe that as we bring more attention to this epidemic, there will be more resources that follow. I think that as soon as Congress gets their hands around this, arms around this issue, that we may see more resources. So, as Secretary Gobet had mentioned, this shouldn't be Medicaid only. We believe that Medicare should get involved. And there should be other resources available as well. So this is just a starting point. I don't think this is an ending point. And to have the president at least acknowledge that this is a public epidemic, that we should at least acknowledge that that's a step in the right direction.
Do you think the president will put resources behind that acknowledgement? Are you optimistic about that?
Well, I believe in time that will happen. But again, I'd hoped that we would have more resources at this point in time. But again, we should just at least acknowledge that it's a step in the right direction. Commissioner Levine, there are some aspects of this that are helpful in terms of identifying this as a public health.
There are some. Most of them involve within the federal government transfers of money or resources, human resources, to help manage the epidemic, if you will. But there's very few new resources that have been identified from a financial standpoint.
If I could just add in quickly from Senator Sanders' perspective, the president could have chosen to do this in a way that added additional resources if he did it as a national emergency, but doing it as a public health emergency limited the amount of availability to provide new funding. So the funding shifts that the commissioner was speaking to, it's just moving money from one pot to another. This could have been done in a way that was actually brought in emergency dollars. It was not.
I know I said I was going to stop asking questions, but you also, Dr. Levine, you mentioned SAMHSA pilot in your remarks? What was the pilot?
So the pilot is actually trying to find those individuals with opioid use disorder that haven't freely of their own will walked into a treatment center, made a phone call, identified themselves as interested in treatment. But we know that they're out there, just based on statistics nationwide. So the pilot actually involves a technique called respondent-driven sampling, which is trying to identify who those people are, usually through the contacts they have in people who are already receiving treatment. And it's called the snowball type effect, where when you know one person, you know a number of people. And people in the using community, if we could call it that, know each other. So it's actually an effort to have people who are actually positively responding to treatment encourage their colleagues to also respond to treatment. So the state of Vermont and the state of Alabama are the two states that have been selected.
I have one more question. What kind of advice or pressure is being put on the pharmaceutical community on their end to avoid overprescribing drugs that can lead to addiction?
Well, and again, I may let Dr. Levine answer some of that, but we did put in measures for overprescribing. So I thought that was a step in the right direction. But further, Dr. Levine.
Right. Your question emphasized the pharmaceutical industry, but it's really the prescribers that it is really directed at. And the new prescribing rule, early data is already showing an impact of the prescribing rule, which it's very early because it began July 1st, so I don't want to give you firm numbers that don't have as much meaning as they will several months down the road. But even before the July 1st date, we were seeing decrements in opioid prescriptions because there was a greater knowledge out there about the harm of opioid use on a chronic basis, about the potential for addiction after just a short prescription. And so how short should that prescription be and what dosage would be appropriate for the condition being treated? So lots of people were already becoming more familiar with that even before the formal rule went into place.
Is anyone able to talk specifically about what the waiting list was like in Franklin County prior to BART opening and what it will look like now that you're here?
Sure. It's hard to really grasp what the number was like before we were here. I will tell you, I can give you some stats, though, that will be helpful. There were 90 patients, roughly 90 to 100 patients that were traveling every day to Burlington from this area to go to the Chittenden Clinic. There was another 38 patients that were traveling 7 days a week every day to Newport. And a lot of that was public transit, whether it be GMTA or RCT. So when you look at the cost of what we were spending on public transit, and don't quote me on this, which I know you're going to, it was roughly, and I believe it was Shumlin that had said this in our press conference last summer, it was $1.2 million just to transport our patients. Now I will tell you this, if you're a patient and you have to go from St. Albans to Newport 7 days a week, that's a good 3 hours round trip. And in the winter, it's 4 to 5. How are you expect to have a job? How are you supposed to succeed at life? So when we opened this clinic, and the reason that we partnered, well, we didn't partner, but the reason that Jill gave us some space at the hospital is so we could stop those routes as quickly as possible. So the first people that came through the door were people that were going to the Chittenden Clinic, people that were going to Newport. And I can tell you the results and the success that we've seen from those patients already is mind-blowing. They have a lot more time in their day now where they can focus on their treatment, but they can focus on other things as well.
And what is your waiting time?
We don't have a wait time right now.
So you can come in.
Yep, we try to get you in. We're pretty much treatment on demand. And some days we get a little overloaded, so we just schedule out. And we're taking in transfers from other areas, spokes. That's the beauty of this area. The hub and spoke model does work well if you have spokes. We have certain parts of this area of the state where we don't have spokes, and it's challenging. This area, there was 300 to 350 patients in area spoke providers. So we've been working with the pain clinic, Dr. Hawk, Dr. White, and other prescribers in this area, because they've been holding on to a group of patients that they know need a higher level of care and just waiting for us to get here. So they refer them to us. We try to get them stable. Maybe someday they'll take them back. If not, we're going to stabilize other patients and refer them out to a spoke. It's less restrictive.
Any other questions?
With the creation of this hub, do you think there are still other areas in the state that are
sure with the increased need as well, and we're going to see, I would say before this is over, as Jason had said, this facility was built for 700. So we're going to see more need as time goes on. We're also seeing in other areas, I think overall, we can treat anyone at this point in time. But there are geographical locations where there is some issues. So we want them to come to us and identify where there's more need, and we'll take care of that. And so this is an ongoing fluid process, and we just want to make sure that we are there as people reach out for treatment, that we're prepared to provide that treatment for them. Yes?
Question with regard to minimum age of the student, or someone under 18 or under 16 were to arrive at the door. How would you handle it? Not assuming that there are any cases.
It's happened. It's happened. We've had 17-year-olds come into the clinic before. We treat 18 and up. There have been a couple cases where we've had a 17-year-old come into treatment because they were just waiting to get into long-term residential treatment, and for most of them that's out of state. And in both those cases they were in DCF custody at that time. So obviously a parent, a legal guardian, has to sign off on that time. It's not so much the 16, 17-year-olds that are coming in, but our population that we're seeing now is getting younger, much younger. So you're spot on.
Thank you very much for coming in. We appreciate it. Thank you very much for all you do and all your efforts to make this successful.